Hello, good evening to everybody. I hope you can hear me. Welcome to the first of the second series of webinars on COVID organised for the Royal College of Pathologists. My name is Will Irving and I'm a virologist based in Nottingham, and I'll be chairing the sessions. Those of you who joined us for the first series will remember that the very last talk in that series was on vaccines. And like all good series, we left on a real cliffhanger. Would these vaccines save us? Would they work or not? So spoiler alert, yes, they do work, and hopefully they will save us. The last session was in, I think, the end of June, so 6 or 7 months ago. If you think of all the things we've learned about the virus, the pandemic, how we deal with it, what impact it's had on society, an awful lot has happened in the intervening 6 or 7 months. So it's appropriate that we have this series of updates. This will be a shorter series, just 5 sessions on what we could think are the key topics of interest, and that is therapy, vaccines, testing, the pathology, and long COVID. And we have a star-studded lineup of speakers ready to deliver on those subjects. The format will be exactly the same as last time, so we'll kick off with 15 to 20 minutes from an expert speaker, and then we'll have 15 to 20 minutes of a Q&A session. House rules are that it's better if you're muted and your video camera is off. That improves connectivity. Please do come forward with questions, and the way to do that is through the Q&A button, which hopefully you can see certainly at the bottom of my screen, something that says Q&A. So type your questions in there. If you can see that someone else has asked a question that you also want to know the answer to, then do literally give it the thumbs up. Because if you approve other people's questions, the more approvals there are, the higher up the question list it goes, so that we can make sure that we answer all the ones that are most popular. Finally, we are recording this so people can see this at their leisure. Usually it takes a few days before this will get up, but it will be on the Royal College of Pathologists website. I'm told that for the last series there were several thousand views of the series last time. So that's all I have to say. It's now my pleasure to introduce this evening's topic and this evening's speaker. So the topic is therapy, and I'm really pleased to welcome a colleague and friend, Andy Ustianowski. Andy is an infectious diseases specialist working in Manchester. He's also the chief investigator on 3 COVID therapeutic trials and 4 vaccine studies. And he's also on the panel, it's NIHR UPH, I'm not sure entirely what that stands for, but what that panel does is assess all the various proposed trials and prioritize which ones the UK should get involved with. So absolutely the right person to tell us what's happening in therapeutics. So I will switch off now and hand over to Andy.
Thanks so much, Will. UPH stands for Urgent Public Health, but yes, it does exactly what you said. So yeah, thanks, and thanks so much for the invite and giving me the opportunity to talk. I'm going to talk about COVID therapies. I do also have a big interest in the vaccine side, and I'm leading on some of the vaccine research. So I'll be tuning into that one when it comes along as well. I'm going to try and keep to time, but there's an awful lot to talk about. So first off, we need to actually understand what our concept is of COVID disease. And this is a graphic which I've adapted, but has been used an awful lot. And I think it's really important when we start thinking about therapies and why therapies may work or may not work at various stages, and why we're targeting certain areas. So early on in symptomatic disease, the thought is that most of the pathology is related to the virus. Most of the symptoms are related to the virus directly, or the immune response against the virus directly. Some people just go through that phase and nothing more. but a subgroup of people will develop an inflammatory response. And these are the individuals that will largely come into hospital, develop pneumonitis requiring oxygen therapy. And a subset of them will develop what is known as the cytokine storm, where really there is uncontrolled inflammation going on, and we'll be touching on that. And at these latter stages, the inflammatory phase, and particularly the cytokine storm stage, probably there's relatively little virus around, and the pathology is no longer related to the virus. So if we just remember that as we're going through, that'll be useful. So I'm not going to talk about the life cycle. There are people who are listening, and Will would be one of them, who are much better at this than I, but it's really to introduce what I'm going to start off first, which is the antiviral therapies, and then I'll move on to the immune modulating therapies later on. So I just want to touch on one particular study, because it is the study that's informed our guidelines and the data that we have more than any others. And I want to pick it up because it's a UK study. It's the recovery study. It's an individually randomized, open-label platform study based in the UK, prioritised by the UPH committee that you mentioned earlier on, taking place in about 176 hospitals. Hospitalised patients with either confirmed or strongly suspected SARS coronavirus infection. And you can see on the left there that there's quite a variety of therapies that have gone through this, including the completed ones. And I've underlined the completed ones that are predominantly antiviral. It's quite a soft touch study in terms of its undertaking and its performance and its endpoints. Really, the key endpoint is mortality at 28 days post-randomization, but also data on discharge from hospital and whether people end up having invasive ventilation if they're not already ventilated, and obviously death. So, rattling through, what has it told us? Well, it's told us various things don't work. So, Donald Trump, the ex-president of the United States, as of a few hours ago, was an advocate of hydroxychloroquine, as were quite a few other people. And this is really the main study that put the nail in the coffin for hydroxychloroquine. There were an awful lot of people, as you can see, numbers at risk, 1,500 with over 3,000 controls. And there was a numerical trend to actually worse outcomes with hydroxychloroquine compared to usual care. But overall, there was no significant difference. And on the right, hopefully you can see that there's no subgroup that particularly seemed to benefit from hydroxychloroquine. So it told us hydroxychloroquine doesn't work. It's also told us that Kaletra, or Lopinavir, ritonavir, an HIV drug, does not work. The lines on the left are really almost exactly on top of each other. And again, the forest plot on the right doesn't show any subgroup which seems to benefit or otherwise compared to any other subgroup. And we've more recently had data on azithromycin showing exactly the same, no efficacy. So no efficacy, hydroxychloroquine, Kaletra, azithromycin. Now, I want to leave the recovery study for a bit. I will come back to it. And what I want to do is focus a little bit of time on remdesivir. And the reason is this is quite controversial, and I think it's worth exploring the data, and then we can decide where its use may be or not. For those of you that work in HIV and in certain other viral diseases, this is a well-known mode of action that is for the nucleotides and nucleosides in HIV. As the RNA chain is progressing, then remdesivir triphosphate gets incorporated, and rather than an immediate chain termination, which happens for our HIV nucleosides and nucleotides, there's a delayed chain termination. But effectively what it means is that RNA replication is halted. Is it relevant that it's a delayed chain termination? Well, the company Gilead who make it think it may have a relevance in decreasing resistance development, but I think we've got to wait and really find that out in the future. The main study, I would say, was the ACTT1 study, which is what I'm going to talk about next. But then I will touch on the WHO Solidarity study, which is where the controversy happens. So this study took adults with confirmed SARS coronavirus to infection, and they're unwell with infiltrates or needing oxygen or having low saturations, etc. And they're randomized to placebo or to remdesivir for the 10 days. It's an intravenous therapy. And this is the headline data. So if you were on remdesivir, you actually recovered about 5 days earlier than you did if you were on placebo, from 15 days down to 10 days, to a level that would be suitable for discharge or being medically fit for discharge. Another way of looking at it on the secondary endpoint would be odds of improvement by day 15, and hopefully you can see there's statistically significant improvement, odds ratio improvement in those that received remdesivir. So it seems to have an activity that means that people get better quicker. But it had no impact on the main mortality endpoints in the study. There was no obvious difference in outcome of death. Now, there has been some slicing of the data, post hoc analyses that imply that certain subgroups may have a mortality benefit, but I'm going to gloss over that because that's post hoc data, and I think there's other messages we can get from a meta-analysis I'll talk about in a second. So, as I did before, are there any particular groups that do better or do worse on this therapy? Well, the forest plot is largely biased towards the right-hand side there, with some wide error bars around a few of them, showing that remdesivir seemed to work for most people, except right at the bottom. If you were receiving high-flow oxygen, non-invasive ventilation, or you were mechanically ventilated, or indeed on ECMO, extracorporeal membrane oxygenation, which not many people were, the impact of remdesivir was abrogated and perhaps not there. But otherwise, depending on ethnic group, race, geographical region, age, sex, or indeed possibly symptom duration, there was no obvious impact, except symptom duration. The statistically significant difference was in those that had symptoms for less than 10 days when they were randomized. So that's the ACTT-1 study. What about the WHO Solidarity study, which has reported since? Now, this was an adaptive platform, a little bit similar, I suppose, to the recovery I mentioned, quite large scale, over 400 hospitals in 30 countries. And it didn't just look at remdesivir, it looked at a variety of other combinations and treatments you can see there. But you can see remdesivir, just under 3,000 individuals. Now, the Solidarity results on mortality showed no difference between remdesivir or control. And what I hope you can acknowledge on the bottom right there is this is actually consistent with the ACTT-1, which also did not show a benefit in mortality. People have put these two studies against each other, but for this endpoint, they're in agreement. Where they're not necessarily in agreement is the time to discharge or the time to recovery. In Solidarity, there were no positive findings. There was no obvious impact of having remdesivir and being fit for discharge or being discharged earlier. Now, personally, and this is my personal view, I think there's some flaws here, which I'll allude to now. This was an open label study, and this text I've taken from the actual report, which is in the New England Journal. Patients who would be considered fit for discharge might be kept in hospital somewhat longer just because they were being given the trial drug. And in fact, for the 3 trial treatments that were scheduled to last for more than 7 days, more people ended up in hospital for more than 7 days. So in other words, it's likely that the investigators all around the world were possibly keeping people in hospital to complete their open label randomized therapy. And each drug delayed the discharge by approximately 1 to 3 days while it was being given. Now, to me, this makes me think that any benefit on time to recovery or time to discharge may well be obscured because people were perhaps being kept in hospital just to complete their randomized therapy rather than being discharged when they were fit enough to go home. And this is key because, okay, mortality is a hard endpoint that's really, really important. But if we're taking people early in their hospital admission, the majority of those are not going to die. But actually, if we look at our hospitals now, and if we could get people out of hospital quicker, 5 days quicker, that would have a significant impact on not only our health systems and our hospitals, but actually on those individuals. They'd much rather be home with their families, etc. So it's a key point to decide where we're actually going to use remdesivir. If we look at the Solidarity meta-analysis that they did in the same paper, combining the data from the ACTT-1 study with their data and a variety of smaller studies, I've highlighted, and you might not see it, but I've highlighted something at the bottom, which is this is mortality. And they've looked at those who were not on ventilation, admitted but not on ventilation. And there does seem to be a trend to a decreased mortality on remdesivir, which almost meets statistical significance. The upper error bar confidence interval is 1.01. So with more data, maybe we'll start seeing a mortality benefit as well. So what are the remaining issues with antiviral therapy? Well, there are a variety of other antivirals which are being researched at the moment, and we don't have data made by companies like Merck, Pfizer, etc. So they work in different ways, and so it's going to be very interesting as we start, I hope, getting data on those over the next couple of months or so. There's also an issue of timing and setting. If you remember that first graphic of the pathology being virally mediated earlier and later on being more inflammatory mediated, you would argue an antiviral is going to work early on and not later on. And we're quite used to that with antivirals, actually, whether you're looking at influenza or you're looking at herpes simplex or a whole variety of other ones. Ideally, it would be nice to think that actually antivirals may have a role pre-hospitalization when people first have symptoms to avoid hospitalization. Now, that won't work at the moment for remdesivir. It's intravenous infusions only, though preparations that are nebulized or dry powder inhalation are being prepared. But some of the other antivirals are oral, and so I think it'll be very interesting to see what data we get from those. So what about immune modulation? What about the right-hand side of this graphic? Those with an inflammatory response giving them pneumonitis, and perhaps those that get a cytokine storm, of which the majority probably end up on intensive care. So cytokine storm's very interesting, and there has been a very recent, in December, review article in the New England Journal on cytokine storm on the back of coronavirus, but it does talk about cytokine storm from adult onset Still's disease or CAR T-cell therapy or whole other therapies. Now, I've just taken a little bit of one of the graphics from that because I think it's key. I mean, the inflammatory cascade is very complicated with a lot of negative and positive feedback loops, and you can develop this real kind of positive feedback and this cascade that happens. But highlighted on this graphic are certain drugs like infliximab and anakinra and tocilizumab and steroids. Now, all of these are under investigation in coronavirus. Not all of them are reported, and I'm going to really focus on steroids and tocilizumab first. So let's go back to the recovery study, that UK platform study, which I think has done more than any other study so far. So let's look at dexamethasone. Well, here we can see, I hope you can see, that the line for mortality for dexamethasone is lower than the line for usual care. So in other words, mortality is improved. And if we were to look at the forest plot on the right, it's particularly in those who have invasive mechanical ventilation or are requiring oxygen. Those people hospitalized with COVID but not requiring oxygen did not get a benefit from steroids, but there was a significant benefit overall. Now, what does that equate to? So there's a little calculation here. So the invasive mechanical ventilation mortality was reduced by 1/3, and those not on ventilation but on oxygen by 1/5. But that actually equates on an intensive care setting to 1 life saved for every 8 individuals treated, or in the ward-based oxygen therapy side, 1 life saved for every 25 treated. So a huge impact potentially on our pandemic, and really, really important. This is dexamethasone. We have some data from some of the other studies of other steroids having a similar effect. So it's probably a glucocorticoid effect. What about tocilizumab? Now, tocilizumab has been tried right from the very early days, because once the cytokine storm was recognized, which was really within a few weeks of coronavirus or COVID being identified, even if it wasn't called it then, people realized that interleukin-6 was probably a key factor. And there have been a variety in the early days of tocilizumab studies which were largely underpowered or not necessarily well designed. There's still a few to report which are well designed, but I've taken publications that are really just from the last 6 weeks, so just from December and January, on tocilizumab, where we have better data, and I've just looked at those that are controlled studies rather than retrospective studies. So we have the top study, which is moderately ill hospitalized patients from the States, and moderately ill meant they either needed oxygen or they had chest infiltrates or they had low oxygen saturations. And that particular study did not show a benefit in preventing intubation or death. However, they comment that the confidence intervals were wide. So that didn't show an effect, and I've made that red. But if we look at the next study down, also from the States, looking at those hospitalized but not on mechanical ventilation, there was a statistically significant reduced likelihood of progression to a composite outcome of ventilation and death, though on its own it didn't improve survival. Another study looking in a similar scenario, those needing oxygen but not intensive care, no difference in the 28-day mortality was found, but a borderline reduction in the requirement of progressing to non-invasive ventilation, mechanical ventilation, or death. And what's really important is REMAP-CAP, which I haven't mentioned yet, but is a UK and international platform study of those in intensive care, largely intubated, but not exclusively, but within an intensive care setting, was a press report which has shown a significant improvement in mortality, an odds ratio of 1.64. So a huge improvement in, and here we can see deaths went from 35.8% down to 28%. So quite a wide variation in data on tocilizumab. REMAP-CAP is very well designed, and we're really waiting for the full publication to come out so that we can assess the true impact of tocilizumab. What about other evolving areas in the immune modulation side? Well, we've got convalescent plasma, we've got monoclonal antibodies, we've got antithrombotics, and many other areas. So I'm just going to touch on those in the few minutes remaining. So convalescent plasma, don't necessarily look at the graphs here. This is just for me to say there were a lot of retrospective and uncontrolled studies in the early days of coronavirus, which tended, on average, to show a little bit of a benefit, but were all flawed. We've now got much better data. I've taken this example, which is from Argentina, of a placebo-controlled study with reasonable numbers, which actually didn't show a significant overall benefit of having convalescent plasma on hospitalized patients on time to discharge and clinical improvement. I'll just flag up on the right-hand side two factors. It's not really important, the numbers here, but I'm going to come back to them, which is in this particular study, the median time from the onset of symptoms to enrollment and therefore receiving the convalescent plasma was 8 days. And they've alluded to the titer, the median titer of antibodies against SARS coronavirus 2 within that convalescent plasma. And I'll come back to that in a second. So convalescent plasma in this randomized controlled study didn't show a benefit. And if we think about REMAP-CAP, that ICU platform, on the 11th of January, the arms recruiting to convalescent plasma in those on intensive care were closed as there was no improved outcome seen. And this is Bayesian. In fact, both this and recovery are Bayesian analysis, so they continue until they've either shown futility or a significant improvement. There seemed to be futility. And actually, 4 days later on, the recovery study, the study I mentioned first, also stopped randomization to convalescent plasma as no significant difference in the primary endpoint of 28-day mortality was seen. So not so good for convalescent plasma at the moment. Where does this leave it? Well, it might just not work. Or it is possible that we're not giving it early enough, or the plasma used was too low a titer, which is why I alluded to those factors from the Plasma AR study. We don't have the data as yet from recovery about the time from symptom onset, and we don't have the data on the plasma titers in either of recovery or REMAP-CAP, but it's not looking quite so good for convalescent plasma at the moment. Now, I put convalescent plasma here, not necessarily because it's immunomodulatory, you know, its actions are partly immunomodulatory, but also antiviral. So just bear that in mind, why the timing is so important. Now, what about monoclonal antibodies, which are also potentially a kind of antiviral? So there's a variety of monoclonal antibodies against the spike protein that have entered into studies and are now reporting. So the data to date on the monoclonals for treatment in non-hospitalized individuals, we've got the Regeneron and the Eli Lilly combinations, which have shown a reduced viral load, but we don't yet have data on clinical outcomes. And there is data from hospitalized individuals without end organ failure where the Eli Lilly monoclonals were added onto remdesivir, and there was no added on benefit seen. So I think we need to await more data in the therapeutic side of monoclonals. I think they're very interesting in the pre-exposure and the post-exposure prophylaxis side, and there are ongoing research in the UK and elsewhere that haven't yet provided data. Thrombosis is an important issue. This is Royal College of Pathologists, and I'm sure there's some histopathologists in the audience, and they'll realise, if no one else does, how much clotting goes on in those that die with COVID. There's thromboembolism and there's thrombosis in a variety of locations. So what about therapeutic anticoagulation rather than prophylactic anticoagulation? So on the 23rd of December, we had data that came from REMAP-CAP predominantly, but in combination with 2 other studies, more in the intensive care setting, where they were looking at full therapeutic dose anticoagulation compared to normal prophylactic dose anticoagulation. And there was no evidence of any improved outcomes. The enrollment in these studies do continue in the ill hospitalized non-ICU type patients, but at the moment, there's no evidence to support full anticoagulation rather than prophylactic anticoagulation.
Andy, we're coming to the, are you coming to your last slide?
I am. What good timing. So in the end, we're probably going to need a combination of multiple therapies because antiviral, immunomodulatory, etc. So I think we need to bear that in mind. And there's my summary. I hope the timing worked out okay.
Fantastic. Many thanks. You covered a lot of ground there, and it's really good to see the trial data coming through, even if some of it is disappointing. And I remember we did a special session on convalescent plasma. It was a huge effort to collect all that convalescent plasma, and it's a real shame that it doesn't appear to have value. Okay, so some questions. One from me, first of all. There was a lot of interest at the start in ACE blockers as drugs that might prevent virus entry. Did that just sort of fizzle out?
Yeah, it kind of fizzled out. I'm not aware of any large-scale studies, but all the observational cohort studies didn't really show anything. There was also interest in the other perspective, which is whether, because we knew quite early on that those with cardiovascular disease and those with hypertension were more at risk of severe COVID. So actually there was a thought about, is there a subset of people on ACE inhibitors that for whatever reason, they get worse disease, but actually neither has been apparent. So I think people can carry on their ACE inhibitors for their heart disease. It won't help them, but it won't necessarily make things worse.
Okay, this is interesting. A couple of people have mentioned ivermectin, an antiparasitic.
Yeah. So it is being actively researched. So it's going to be in a couple of platforms in the UK, actually. So it's being actively researched in the UK. Ivermectin seems to work for an awful lot of things, which is, I think, what I'm just getting the questions up as well. The parasitic wonder drug. Yes, I agree. No real data. We have to be really careful in the time of coronavirus and COVID, not to base too much on, cohorts of 10 people, poorly designed studies, non-randomized studies. This is where we started with the whole hydroxychloroquine story. So I'm going to be watching the data, but I'm not convinced. Let's wait and see what comes up. Nothing that's convincing me or anyone else that it should be a treatment used out of studies at present. Okay.
One of the key variables in all of these trials is what point you start the drug, and the tendency, I think, you obviously you start with the very seriously ill who are already seriously ill and you want to make them better. But drugs that fail in that situation might work if you'd only started them before the patient got seriously ill. And I wonder if remdesivir is in that category.
Yeah, my gut feeling is it probably is, not just remdesivir, but the antivirals. If we could work out how best to give an antiviral really early on, your first symptoms when you've been to your testing center and your swab comes back positive, pop a few tablets or pop the nebulized or the inhaled remdesivir. It can't be made into a tablet formulation, unfortunately, but the others can. That, I think, is the most exciting area. Now, it is not yet evidence-based, so we need to bear that in mind, but it seems logical with what we know about the early symptoms being virally mediated. And if we shut things down at that early stage, I would be optimistic we might see something, but the studies need doing, obviously. But I think you're right.
So the question is, are they being done? I mean...
yeah. So there are studies of remdesivir intravenous infusions in the pre-hospitalized patients, but they're not really something that fits into the UK setting. we don't have a setup really to bring people up for an hour-long infusion, and then they're supposed to be observed in the study for 2 hours afterwards. That's not really practical in the UK setting. There are some infusion centres, I think, in the US which are beginning to do this, so they're looking at it. And when they have their nebulized and dry powder inhalation, I think that opens up a whole lot of avenues. The oral antivirals are pursuing that route. And there are some sites in the UK that are doing it. It's actually not urgent public health badged, but there are some sites in the UK that are doing that, and globally there are. So I'm quite optimistic that we will get data, and that's where the data is going to be good, I hope.
Okay, Abdul Salam has added a comment. The results of CPT showed unfavourable results. I'm not sure what CPT is.
I think that's convalescent plasma therapy, maybe. I'm guessing. The answer is yeah. So, you know, if you look at the literature, and if you actually just put in convalescent plasma, you'll probably get 50 different studies coming up. Some of them, you know, we look backwards at 20 people we gave it to, which I don't think are valid in today's world when we've got randomized controlled studies. It's not looking promising right at the moment. But I don't think we can shut the door on it completely. If it can be given earlier, and there was an editorial in the New England Journal last week or the week before in a paper that implied, actually, if you can give convalescent plasma within 3 days of symptoms and high titer convalescent plasma, maybe there's an effect. So there's still a little bit of work to do to make sure we don't, you know, burn that bridge. It might still have a utility.
Okay, a question on the side effects of the immunomodulatory drugs. So are you going to put patients at risk of other infections whilst they're on? Yeah.
So the answer is quite possibly, but on balance, that is significantly outweighed by the potential benefit. If you look at the dexamethasone, the outputs were really 28-day mortality and going home. So it does bring in the whole factor of secondary infections and other problems. You know, steroids do. Tocilizumab probably does. But if they have efficacy, and for the tocilizumab, that remap cap data will be really important, it outweighs the risk, I think, and it's definitely worthwhile. I'll just point out, actually, you know, that the temptation, including in my practice, actually, in the early days and now, is quite often to give antibiotics to people at the front door as they're coming through, because they've got a pneumonitis, and you think, well, maybe there's a bit of bacteria in there as well. It's actually a very low level. When we look at the data. So almost all that antibiotic is being wasted and just encouraging antibiotic resistance. On an intensive care setting, slightly different. Once you're on a ventilator, then obviously you are going to be getting more secondary infections. And then I think antimicrobial use should be thought of reasonably early, and in fact maybe aspergillus is a risk factor there as well. But overall, these modalities that we're looking at, the immunomodulators, I think the benefits will outweigh the risks.
Okay, so there's a long question or comment here from Osama, which relates to something we were chatting about beforehand. That is, we're seeing a huge amount of hospital-acquired infection, and we know, as we diagnose somebody who's been in hospital for 3 weeks and all of a sudden they turn up positive, we know who they've been in contact with, and we could do studies of immediate prophylaxis. And the suggestion from Osama was start giving them IV remdesivir. And I know you're involved in a study on monoclonals. Do we have any information at all that they work?
Yeah, so there is one of the studies that I'm doing is what's called the Storm Chaser study, which is in about 8 locations around the country, which is giving some monoclonals intramuscularly to those that have had contact with a confirmed case within 8 days. So I think we'll get some very interesting data, I hope, from that. It's far too early. We're recruiting at the moment. I wouldn't expect data for at least 2-3 months or so. So I think that's one possible modality. And there's other monoclonal companies that are thinking about going into the same area, including in the UK. I do think the oral antivirals may have a role here as well. I'm not aware of any studies, actually, of the post-exposure prophylaxis with the oral antivirals. Remdesivir is not in that area of the post-exposure prophylaxis as far as I'm aware. And again, the logistics of actually giving people an hour infusion really get in the way. But that might open up a little bit if we get the other formulations of that. So I think the post-exposure would be a fabulous area to get more data on. I'm hoping that the monoclonals are going to work, because it sounds like a very sensible idea, and they float around for 6 to 9 months. So the other fact about giving something like remdesivir is, well, if you then develop symptoms and become viremic a few days later on, you might have missed your slot, type of thing. So let's wait and see.
Okay, a question has just popped up, which may not be in your area, but it's to do with the low levels of oxygen, and the question is, what's going on in the lungs compared to other pneumonitis or infection in the lungs?
I just got that. Yeah, I just saw that as well. I think that's a really interesting question, and it's not in my area for this talk, but it is in my area. You know, right from the early days, we realized there were a lot of people needing quite a lot of oxygen or having low saturations who weren't puffing away and were talking quite happily. And it does seem to be that a large group of people don't get what we call air hunger. They don't, for some reason, detect their hypoxia and have that same response of being panting away and not being able to complete a sentence. There's a lot of interest on whether that is related to the loss of taste and loss of smell that go on with COVID and how it all interacts. But it's an interesting fact that I'm not sure actually we fully know. But the observations are entirely correct there.
Yeah. Okay, Osama's asked about the storm chaser, but we've discussed that, and yes, potentially.
It can be in a hospital setting, it can be in an outpatient setting, it can be in a workplace-based setting. So hopefully it's going to give us some good answers.
Yeah. Tocilizumab got a lot of publicity last week on the radio and the television about what a lifesaver it was going to be. What precautions do you have to take in giving a monoclonal like that, and what screening do you do before you start it?
Right. Well, if we base it on the studies, which is where it's coming from, really, there was the Cavacta study and the Remdacta study, and now REMAP-CAP. Basically, if you had a severe ongoing untreated infection, you shouldn't be enrolled. So if someone's got rip-roaring cellulitis or a rip-roaring known other chest infection or urosepsis, then perhaps delay it until you've got it more under control. Then I think once it's under control and going the right way and you've got it covered with your antimicrobials, basically let's just go for it. We're talking about a severe situation here. There's not time to screen people for tuberculosis or other factors. You may not have returned your bloodborne viruses, etc. And I think that's the setting we're in. So I think unless there's an overwhelming sepsis, if the data that we've got that's coming out of REMAP-CAP remains the same when we see the final publication, basically I would just give it. If it's me that gets bad coronavirus and I'm entering into that phase, just give it to me. Don't bother with all that screening. You can do the screening, but don't wait for the results.
Okay, that's very interesting, because I've seen the long list of things we're supposed to screen for, and we're sort of thinking, oh my God, how are we going to do that?
I think send the screens, but I'm very hesitant about waiting 3 days for something to return, like your early spot for TB or something, and then you've missed the boat, really. So I think we have to be a little bit pragmatic. Data, I hope, will come out in the publications and the further studies to inform this a bit more, but I think we just go ahead and give it if it's proven to be effective.
Okay, the next question is that thorny group of patients who look for all the world as though they've got COVID, but we don't have a positive test. They're really difficult from an infection control point of view. Where do you put them? Presumably you simply manage them in exactly the same way, or do you?
Well, I think there's probably 2 ways of looking at that. I think the first thing is, our tests are not 100% sensitive. So, we have people who undoubtedly have coronavirus, and it's confirmed later, who have multiple oral pharyngeal swabs which are negative. So nothing is ever 100%. If it looks like COVID and smells like COVID and you've excluded other causes clinically, then I think treat them as COVID. The other factor, though, which came up from that question, I think, was, well, what if someone's well? Well, then, and they just have a mild chest infection, well, then I'd watch them, really. This is relevant because a lot of the studies, the studies are of people with COVID, not just asymptomatic coronavirus infection. I think if you've really got asymptomatic or very poorly symptomatic, then at the moment we don't have a modality or a therapy that's going to work. I would just watch them to make sure they don't develop pneumonitis or become worse, and then I jump in there with the dexamethasone or the remdesivir or whatever else is happening.
Okay. Vitamin D comes up in all sorts of infections. We've discussed this in the context of Hep C. Any evidence that vitamin D deficiency is important and vitamin D supplementation is useful?
Okay, well, there's two parts to that as well. So the first bit, is there any evidence that vitamin D deficiency is important? Well, it does seem that vitamin D deficient people are more likely to get severe disease. But that doesn't necessarily correlate to the second bit, that if you give vitamin D supplementation, that abrogates that or gets rid of that, because it could be a confounder, or it could just be that supplementation doesn't make a difference. So that there are studies. There's one called Coronavit, which has just finished recruiting, which is actually looking at giving vitamin D supplementation. So vitamin D is very interesting, but we don't as yet have data to say that supplementing makes a difference.
Okay. Key question, reinfection. Have you seen patients who have evidence that they've had 2 infections?
We have, not very many, but we've had people in wave 1 who had a confirmed positive swab, and now in wave 2 or wave 3 or whatever we're in at the moment, have a positive swab. Some people with less severe, and a few people with more severe disease, actually. So we are seeing that. Now, I guess we expect that. There are different immune responses that people who have clinical coronavirus have. We may get different responses to the vaccines. Now I'm encroaching on my other hat, which is the vaccines. At the moment, I don't think the reinfections are due to new variants, which might be the next question that comes up, but it is something we're going to have to watch very carefully about which of the new variants may have an impact on either the monoclonals or one or more of the vaccines. And it is an area we're actively looking at and trying to get data on. So I think I can't give percentages of people that get reinfection. There's a big study called Siren, which is looking at healthcare staff, that was actually originally designed to answer this question, is now answering other questions, but how many people can get reinfected, etc. So we'll find out a little bit more. Okay,
I think we're coming towards the end, but there's a couple more. So thank you for the comment from Prashant that in the Indian subcontinent there is a lot of vitamin D deficiency, but the mortality is no worse than it has been in the Western world. Interesting observation. Effects on pregnancy. I'm not sure if that's the effects of COVID in pregnancy, if there's anything special about a pregnant woman with COVID, or whether pregnancy would alter the drugs that you have available.
Well, that is a good question. Again, there are observational studies of pregnant people who end up catching coronavirus and seeing. They haven't yet reported to show whether it's more severe or different forms. Some of the studies, including actually recovery, can recruit pregnant women. It's a slightly different randomization that they have. And so it's an area of active interest. Let's wait and see. And vaccine studies in pregnancy are going to be starting in the very near future.
Okay. A comment that, again, patients without upper respiratory symptoms may have horrible looking CTs.
Yeah, and I presume they might well have low saturations as well. Now, I would treat that person if they've got a horrible imaging and hypoxic, at least on saturations. It's really those that are found with asymptomatic disease, nothing really going on, asymptomatic swab, really, screening, that at the moment we don't have a treatment to put them into.
Okay, so if I could try and sum up, sorry, somebody else has just posted some comments. We've talked about vitamin D. How effective is the vaccine? We'll find out in 2 weeks' time.
Yeah, I don't want to steal anyone else's thunder. I can give you numbers, but I'm not going to. There you go.
If I could just sum up, the difference between the first therapy talk we had, it was one of the early ones, and your talk now, is that we do know that some drugs work. So in routine practice now, you would say every hospital in the UK should be offering dexamethasone to any patient going on oxygen therapy?
Yeah, I would say yes, unless there's an obvious contraindication, and there won't be very many. Anybody who's requiring oxygen, all the way to being mechanically ventilated, should have dexamethasone. You know, it's the strongest signal we've had of a decrease in mortality. So absolutely. Remdesivir, which might be your next bit, a little bit more controversial. You know, I'm in favor. I prefer the ACTT1 study from the Solidarity study for the reasons I mentioned. And I do think, actually, 5 days getting out of hospital earlier, if that's what is really happening. So that's more controversial.
Okay, and finally the Tocilizumab, that is for any patient entering ICU?
Well, that is controversial. We don't have the written peer-reviewed article as yet. The government has allowed it to be used by ICU physicians on the basis of the REMAP-CAP data, but it hasn't yet necessarily become standard policy as yet. And it may not. Let's wait and find out.
Okay, well, that's fantastic. Thank you so much for the talk and for standing up to my inquisition. You did a fantastic job, and it's really brought us up to date. So all it remains for me to do is to invite everybody to come back this time next week. The topic will be testing. The title is Testing for SARS-CoV-2 RNA Bigly, which is an unwelcome reminder of the last 4 years that we've just now escaped today through President Trump. That will be given by Dr. Malur Sudanva, who is the virology advisor to the Milton Keynes Lighthouse Lab. So is well into all the ins and outs of testing. So please do register. I think it'll become open for registration tomorrow. If you want to see this talk again, go to the RCPath website in 4 or 5 days. And otherwise, thank you very much to everybody for attending. Thanks for all the questions. It's fantastic how we get all these questions coming through. And I look forward to seeing you next week. Bye for now.